All right, welcome to the pre-lecture recording for bipolar affective disorder. I will try to make this pre-lecture recording considerably shorter and quicker than the one that I did for psychotic disorders. So here is the suggested reading. Again, this is just from DePiro. As for the lecture objectives, this recording is pretty much only going to cover the first objective, which is just that by the end of it, you'll be able to identify and discriminate between various bipolar affective disorder symptoms and diagnostic criteria. For the diagnosis and overview, there are several subtypes of bipolar affective disorder, or BPAD. Bipolar 1 disorder means that somebody has experienced at least one manic or mixed episode, and a mixed episode is where somebody has symptoms of both mania and depression. And they've also experienced at least one major depressive episode in their life. In bipolar 2, while the person may have experienced at least one or multiple major depressive episodes, they've only experienced hypomanic episodes and never an episode of full-blown mania. And we'll talk about what the diagnostic criteria for these individual episodes looks like. Cyclothymia is somebody who has experienced hypomania, which is less severe than full-blown mania, and depression, but the depression does not meet criteria or full criteria for a major depressive episode. There are some specifiers. People may have anxious distress, mixed features, rapid cycling, psychotic features, and catatonia, and we'll talk about what some of those mean. For the major depressive episode, the diagnostic criteria are identical to the diagnostic criteria that are for major depressive disorder, and so I'm not going to go over these one by one. If you have any questions, don't hesitate to ask, but just know that for somebody to have a major depressive episode as part of bipolar disorder, all of their symptoms need to meet all of the diagnostic criteria for even major depressive disorder as well. So, for a manic episode, this is where it gets a little bit more interesting and some new material. A manic episode means that somebody's had at least a week of elevated, expansive, or irritable mood and at least 3 of the following. If their mood is irritable, so it's not elevated or expansive, but it's only irritable, then they have to have at least 4 of these features. So, inflated self-esteem or grandiosity. So somebody thinks that they're the greatest person to ever walk the earth and that everything that they do is amazing. Decreased need for sleep. This is one of the hallmark symptoms of bipolar, or rather of a manic episode, is the decreased need for sleep. This is not somebody saying like, oh yeah, I only need 5 hours of sleep. This is somebody going for like at least a week, so this is at least a week of having maybe 1 hour, maybe 30 minutes of sleep in a 24-hour period every single day for at least a week. People can go for a couple weeks like this. It's really dangerous. People are hyperverbal and have pressured speech, so they're talking a lot, they're using lots of words, and it's very pressured in a way that there's like no space between the words that they're using, and it's very hard to get to interrupt them. They'll have racing thoughts, also called flight of ideas, if they just keep coming up with new things to talk about. They're very easily distractible. They may be looking at you talking about one thing, and then they see something go by, and then they're quickly distracted to talk about that other thing. They'll have increased goal-directed activity or psychomotor agitation. So while these don't seem totally related, they can be. So the psychomotor agitation is that they're kind of ramped up, they're more active, they're moving around a lot more than usual, and that could be related to their increased goal-directed activity, which is that all of a sudden they decide they're going to finish doing something that they've never even thought of doing before, or they're going to figure something, I don't know, they're going to like read the entire Encyclopedia Britannica because they want to or something, just to kind of give you an example of that goal-directed activity. They may also have increased risky behavior, and so this can look like a variety of things, but maybe they're spending way too much money that they don't have. They may be participating in some sexual indiscretions, poor judgment in business ventures, just across the board, anything you can imagine that would be risky or involve poor judgment, they might be participating in those things in an episode of mania. And then, of course, as you remember, the symptoms are severe enough, or with mania, what's a little bit different is not only is this affecting social and occupational functioning, but mania is a medical emergency. And so what's happening in mania is actually that the symptoms are so severe that it will require hospitalization, or they're experiencing symptoms of psychosis. So in any part of these, in their elevated or expansive or irritable mood, or any of the other criteria that we've just listed, that might involve symptoms of psychosis as well. So for hypomania, which is, like I said, just a little bit less than mania, that is a shorter period of time and a little bit less severe. So what it is at least 4 days of that elevated, expansive, or irritable mood, and at least 3 of the mania symptoms. So the same symptoms that we have here. It's just been happening for a less period of time. And again, 4 of those criteria if the mood is only irritable. However, the symptoms are less severe, and so they're not going to require this hospitalization, and they don't have psychosis. If the person requires hospitalization or has psychosis, that's mania. If they don't require hospitalization or they don't have psychosis, that's hypomania. And if it's been going on for less than a week. Rapid cycling is having at least 4 major depressive episodes or manic or mixed or hypomanic episodes within 1 year. So all this means is rapid cycling is in a 12-month time period, a person has had at least 4 mood episodes, so that's depression, mania, or hypomania, within the last year. With mixed features is something a little bit different. You can have mania or hypomania with mixed features in that the full criteria is met for a manic or hypomanic episode. However, they also have concurrent elements of depression or dysphoria. And dysphoria is just kind of another way to say depression, or having a dysphoric or kind of depressed mood. You can also have a depressive episode with mixed features. So that means that the person meets full criteria for major depressive episode, but they also have concurrent elements of mania or hypomania. You don't usually see them meeting full criteria for both a major depressive episode or a manic or hypomanic episode. It's usually one of the mood episodes is more predominant and more severe, and then the other one is just to a lesser extent. So that's bipolar disorder. Call it whatever episode you want to call it, and then it would have mixed features. So for the diagnostic criteria for bipolar 1, remember that the person has at some point in their life met criteria for at least 1 manic episode. If they've never had a manic episode, then they cannot have bipolar 1 disorder. For the episode diagnosis, it's important to include the episode type. So when somebody presents to the hospital or to the clinic or whatever, you want to say whether or not they're manic, hypomanic, depressed, or unspecified for some reason. You'll want to say how severe that episode is. And you'll also want to make sure to note whether or not the person has psychosis. So maybe they have partial psychosis, full psychosis, or for some reason unspecified. We tend to not like unspecified because it's not specific enough. You may also include additional specifiers, like if the person has catatonia, or if they have mixed features, or if they have rapid cycling. In bipolar 2, remember that the person has met criteria for at least 1 time in their life for a hypomanic episode, but never a manic episode, because if they've had a manic episode, then that automatically means they have bipolar 1. So if they've never met criteria for a manic episode, but they have met criteria for a hypomanic episode, and they've met criteria for at least 1 major depressive episode, then they'd have bipolar 2 disorder. Hypomanic episodes should not be confused with several days of euthymia that might follow remission from a major depressive episode. And this is really important to distinguish, because sometimes what happens is somebody starts feeling a little bit better after a major depressive episode, and because they're just feeling normal again, it's almost like they feel on top of the world and like everything's better. And so it's kind of hard to distinguish sometimes between just feeling normal and feeling hypomanic. And so you really want to always go back to the criteria to really distinguish between the symptoms that the person is, if the person's having any symptoms at all, or if they're just reporting a normal mood state. Again, for episode diagnosis, you'll want to include episode type, severity, and whether or not psychosis is present, and any additional specifiers if needed. With cyclothymia, in these cases, a person's had at least 2 years of many periods of hypomanic symptoms, but they've never met mania criteria, and numerous periods of depressive symptoms, but they've never met major depressive episode criteria. The mood symptoms typically over the course of those 2 years or more, Mood symptoms have been present over half of the time, and the person has never been symptom-free for more than 2 months at a time. And so this was just my attempt at showing you a graph between the person kind of hovering between hypomania and mild depression, hypomania, and then maybe euthymia again. But they've never gone up into mania, and they've never had moderate to severe depression. For the differential with bipolar disorder, we have to consider quite a few things, because people can have mania. That doesn't necessarily mean that they have bipolar disorder. So just remembering that we have to rule out all of these things before we make a diagnosis of bipolar 1. There are medical conditions, or several CNS disorders that they're all listed here that could indicate, or rather that could come along with an episode of mania. People could have certain infections, like meningitis or something, that might manifest with manic symptoms. Certain electrolyte and metabolic abnormalities, as well as endocrine or hormonal dysregulation, can also cause these symptoms. Then you can have several instances of medication or substance-induced mania. So basically anything that kind of alters a person's mind state. So things like steroids or anything that affects dopamine and norepinephrine that might kind of like wake up the person or kind of activate the person could really cause mania. Antidepressants tend to be major culprits for what we call a manic switch. And so basically anything that affects serotonin is can be a big risk factor for causing a manic switch. And so what we talked about in the depression lecture is not only can we sometimes mistreat people with bipolar disorder with antidepressants if they're presenting with major depression, but sometimes if we mistreat them, we can actually cause them significantly more harm by accidentally causing them to switch into mania if we've misdiagnosed their depression as major depressive disorder instead of bipolar affective disorder. The thing is, with the medications and the substances, if the physiological effects of the medication and the substance have subsided, and so think about something like somebody smokes a lot of marijuana and it lasts for a few hours, and then they get manic. Once that marijuana has, like the effects of the marijuana have subsided, we shouldn't see the mania anymore. If the mania persists after that, then they're given a diagnosis of mania and a bipolar 1 diagnosis. It's just the fact that we would expect to see the symptoms of mania resolve once the substance is cleared from the system. Just because the substance induces the mania doesn't mean that the person doesn't have bipolar disorder. It just means that the substance caused their first manic episode. And I can talk about this more if you have any questions in lecture if this part isn't very clear, so please don't hesitate to ask in lecture. The interesting thing is that electroconvulsive therapy and light therapy can also induce mania. So kind of anything that improves the mood is also something that might cause mania, so we have to be pretty careful. For the clinical course of bipolar disorder, the individual episodes of mania or major depression can last weeks to months. Major depression typically tends to precede or follow manic episodes without any period of euthymia. And so somebody can feel depressed, start to feel better, and then all of a sudden have a manic episode. Or they'll have a manic episode, start to come down from that manic episode, and then all of a sudden have a major depressive episode and not really have a period of euthymia or normal mood in between that time. It is common for episodes to recur. More than 80% of patients with bipolar disorder have more than 4 lifetime mood episodes, and untreated patients can have upwards of 10 or more lifetime mood episodes. It's pretty common that somewhere between 5 and 10 years might elapse between the person first experiencing symptoms and actually being diagnosed with bipolar disorder. And part of this is because we need to see, a lot of times we'll need to see both mood states in order for us to be able to say, oh yes, this person does have bipolar disorder. And sometimes those mood states or mood episodes take a while to happen again. So maybe somebody has hypomania at 23 and they don't get hospitalized and they don't become psychotic. They're just really productive and they're just not sleeping very well for a short period of time. And then they don't have anything like that again for 5 or 6 years, and then they have a major depressive episode. So it's quite common that it'll take a while before somebody actually earns their diagnosis of bipolar disorder. We do see the kindling effect in bipolar disorder, and so this is the same as it is for major depressive disorder as well as post-traumatic stress disorder, where we see that the episodes themselves, if untreated, tend to become more frequent and more severe with time over the course of the person's life. Substance use, unfortunately, is quite common in bipolar disorder, and it tends to be a self-medicating strategy that really doesn't work well and usually complicates the picture considerably. And we see quite a high mortality rate in people with bipolar disorder, upwards of 2 to 3 times the general population. For prognosis, this kind of goes with that high mortality rate. There is a high suicide risk in people with bipolar disorder. Up to half of bipolar disorder patients will attempt suicide, and 10 to 19%, or 1 in 10 to about 1 in 5 of patients with bipolar 1 actually commit suicide, and it might even be more than that percentage of patients with bipolar 2. It's common that the suicidal ideation and suicidal attempts are more likely to occur in a major depressive episode or when somebody is in a mixed state where they're experiencing kind of both sides of that spectrum. Psychosocial morbidity is really common in these patients, and this causes their illness causes serious disruption in their interpersonal relationships, which is really unfortunate because it breaks down the social supports that they might have that could be really helping their prognosis and improving their look towards the future. For the epidemiology, almost all patients with bipolar disorder have a relative with a major depressive disorder or bipolar disorder, so it definitely runs in families closely. And the lifetime prevalence hovers around 1%, both for bipolar 1 and bipolar 2, and we don't really tend to see gender differences. The etiology and pathophysiology really aren't understood well. I've listed here several theories. You don't need to know any of them because we don't have a very clear picture about why people end up developing bipolar disorder. When it comes to the evaluation, so this is typically what a doctor in the emergency department or a psychiatrist would be doing in order to evaluate a person with bipolar disorder. You would do full exams, mental, physical, psychiatric, medication, medical, all of those types of exams and labs, of course, psychological testing. But then other times, if you're really concerned about it being a medical illness that's causing the manic symptoms, if it's specifically mania, you might do some imaging to make sure that there isn't something in the brain that's causing these manic symptoms. You might do a lumbar puncture to make sure that there isn't meningitis causing the symptoms, or an EEG to, again, make sure that the brain is behaving normally and isn't having seizures or something like that that's causing symptoms like this. What is a mental status exam? This is really just for your information, but if any of you end up coming on rotation with me or see other psychiatric rotations, you'll see that mental status exams are one of the very common things that are done by psychiatrists and people evaluating people with psychiatric disorders. And so what we do is we tend to evaluate kind of how the person looks, behaves, thinks, talks overall in order to just come up with an assessment of their overall mental status. And you can see just the kinds of things that we will cover, and then these are just a couple examples of types of responses that, or rather assessments that we might have for those different categories. So that concludes the pre-lecture for the bipolar disorder lecture. I'll look forward to continuing this in the in-lecture period. Please don't forget to complete the pre-lecture worksheets, and remember to ask me any questions on Blackboard or in lecture via email if anything comes up. Thanks.